So my talk today is about participation in and through healthcare. So I guess the title of the talk then is about something about participation in healthcare, so participation in decision making and service design and service delivery potentially, but also participation through healthcare. So maybe thinking about participation as a determinant of health. So just so you know a little bit about where I'm based in the Health Board here. So we cover all of the northeast of Scotland. The Health Board looks at about £1 billion of funding a year, and the £1 billion of funding then covers all of our primary and community healthcare across the northeast, as well as all of our hospitals. And we've got a population of about 500,000 people, about 500,000 people in the northeast. So what I'm going to talk about then, 4 broad headings then to take you through. So I think this idea of participation in health, let's start with the politics and let's have a look at what the local political context is in Scotland about participation in the health system. So that's the first thing, and I've got about 3 or 4 slides then, just of major policy documents in Scotland that actually set out the importance of participation and set out expectations of the health system in relation to participation. So we'll set that out first as the broad context. Then we'll think about more specifically, we'll hone in on the health system, and we'll think a little bit about, well, what are the strategic drivers looking at participation specifically within the National Health Service here, the NHS here, both in Scotland, also across the northeast of Scotland. Then I'll give you some examples. So try to give you some real-life practical examples of how we've been trying to turn the political and strategic drivers into real action across the northeast. So I've just picked out 3, and we'll go through those in turn. And then lastly, just to really bring it all together, I'll end with a real-life health system that's actually caught attention of senior policymakers here in the northeast, with a lovely graphic, I think, which actually brings together everything that I'll have spoken about. And I believe we've got about an hour, so we'll bring it in just under an hour. Okay, so without further ado then, political context, and let's think then about all of the different sectors that make up Scotland. So we've obviously got the private sector, we've obviously got private organisations and companies and businesses. We've also got the private realm of the family and the individual. We've got the civic sector, so we've got all of our charitable organisations and our voluntary groups, as well as all of the institutions and organisations that people give their own time to. And I guess the Boy Scouts and the Girl Guides would be an example of that. And we've got the public sector. And so we've got all of the services that are provided across Scotland paid for by government. So let's focus in around this participation agenda around the public sector and think about public services. 2011, the Christie Commission was set up really to look at and come up with recommendations for the future of public services in Scotland. And it came against the context of, so it was 2011, it was against the context of the Great Recession of 2008, i.e. that the money's running out, there's fiscal constraints, there's austerity within the public sector, the knowledge of demographic change in Scotland, so the fact that we've got a greatly ageing population, and the concerns that a much older population puts much greater demands on public services. So we've got money problems, we've got predictions of increasing demand through an aging population. We've got potentially an unhealthy population if you look at things like multi-morbidity. So if we're looking at chronic disease and multi-morbidity. And so the Christie Commission was to look at all of that and to come up with a set of recommendations. And the couple of quotes then that I've taken, I think are relevant to this issue about participation then. What the Christie Commission said then was that public services are built around people and their communities, their needs, aspirations, capacities and skills, and work to build up their autonomy and resilience. And then effective services must be designed with and for people and communities, not delivered top down. So it was that inherent critique that I suppose over the course of the 20th century that we've built up a large welfare state and a very professionalised public sector, and the critique of that in terms of a public sector which professionalises what the problems are and professionalises what the solutions are, and then delivers those solutions onto the people that are perceived to have the issue in question. And really what Christie was saying was we need to move away from that professionalised top-down approach. We need public services, but public services are actually there to empower people. They're there to actually help people to identify what their own issues, concerns and problems are, and to help to co-create what the actual answers to that are, rather than an expert coming in and saying, well, I know what the problem is and I know what the answer is. It's that people actually, and communities actually have the answers to their own issues, and what they need is a bit of support to help them to do that. I mean, Christie, there was a lot of focus in Christie about prevention. So there was a lot of attention paid to not having services that waited for problems to arise and then dealt with them. So not having a fire service that waited for the house to go up on fire and then send the fire engines out to put the fire out, but rather to think what efforts can we do to actually prevent the issues arising in the first place. The fire service in Scotland have actually gone at great lengths to become a prevention service. So that a lot of what they do now is actually working with communities and organisations to look at fire safety and preventing fire. So that's a great example of an organisation which was once very reactive, becoming much more proactive and preventive in its approach. And Christie's challenge to public services was to think like that across all services. What can we do to prevent things rather than simply react to things once they've happened? So from Christie, there were a couple of key bits of legislation that have happened, one of which was the integration of health and social care, which I'm not going to touch on explicitly. The other one was this, the Community Empowerment Scotland Act 2015. And the Community Empowerment Act has a number of sections in it, which are largely all about, just the clues in the name, about empowering communities to shift some of the power from the public sector out to the people. And so one of the things that I've picked out, one of the sections then, is around so-called participation requests. And so this is the idea then that across Scotland now, in law, I'll read out the quote and then I'll explain what the things in blue are referring to. So a community participation body may make a request to a public service authority to permit the body to participate in an outcome improvement process. So if I translate that, what that means, community participation body, it can be a formal organisation or a group, but it can actually just be an informal group of people with a shared interest or shared characteristic. A group of people that come together and say, actually, we've got an interest in, and that they do work in and around the issue that they're interested in. Public service authorities are any of the public sector. So it could be local government, it could be the health system, It could be the police, it could be fire and rescue, it could be our universities, any public authority that receives government funding is a public service authority. And so what it means is that any community group, any group of people that come together for a stated purpose, can basically say, we think that things can be better. And it's effectively, it gives that community body the right to say to any public authority then, we think that we have got something to contribute in terms of the decisions you're making about an issue, about the design of services or interventions that you're thinking about in terms of an issue, or the actual delivery of a service or an intervention. So it actually gives the people the legal right to come and sit round the table and be involved in decision making, service design, service delivery around any issue of the people's choice. And clearly there's a whole process and such like in and around that. And I'll come back to participation requests in terms of some of our work locally around participation requests, trying to make that real. So I'll come back to participation requests. But the point being, we've had the Christie Commission then saying for the whole of reporting to government and saying across all public services in Scotland, public services need to work with people. They mustn't do things to people. So you have to work with people to design and deliver what you're trying to do. Community Empowerment Act puts that into legislation. It gives us all, as citizens, the right to participate. And in fact, I mean, there's a whole suite of sections in the Act that actually empower a whole range of different powers for the public. I wasn't planning to show the video. Oh, but it has popped up. There we go. Just continuing on this political theme then, it's also just relevant, and I just wanted to flag then, that there's a live review going on from Scottish Government just now, looking at local governance. So in terms of the, I gave the reference there, in terms of the purpose of this, it's actually looking at so on the light of the Christie Commission, the Community Empowerment Act, this active review looking at, so how are public authorities actually running themselves at the moment across Scotland? How much are they actually engaging with people, and how much transfer of power has there been from professionals and public sector organisations to communities and people? With the intention of that being to actually genuinely transfer the power to people, give people this much greater say. And it's a nice 2-minute video which kind of captures all of that, which I thought I would give you the link. Okay, so that's the political context. So that's where we're at politically, this large political shift across the whole of the public sector to involve people, to give people a voice, and to shift some of the power out, to give people the power to influence how the world works across Scotland. So let's now focus then a little bit more on health systems and how that's translating more specifically to thinking about the health system context. So thinking here then about our healthcare system, where I'm talking about our both our strategic arrangements in terms of our boards, which set the sort of strategic direction, and then all of our primary care, community care, so our GPs, our practice nurses, our community nurses, our health visitors, our community physiotherapy, our community pharmacists, that whole network of community health system, as well as our hospitals, our outpatient appointments, our inpatient beds and such like. So what is the context for participation then, given that political context? That's what I want to explore with you now. And so again, I've got about 3 or 4 slides then, just to work with, just to take us through some of the thinking that's coming out in and around this. So the first of those, this is a report, joint report, looking at this idea of health as a social movement. This was only published last year, and effectively it was looking at that idea that participation, being involved, having connects, being connected with other people, having purpose, having meaning, all of that is important for health. It's an important determinant for health. So, so the way that a society organizes itself in terms of helping people to connect and to be involved and to have meaning is actually important for health. And it also thought about the way in which involvement in and around the health system actually has an impact as well. So that one of the ways in which people can be brought together then is by actually looking at health issues and looking at helping to empower people to come together to speak about health issues, both in relation to social change, but also in relation to system change and the way that the health system uses its resources, what the health system actually does. So I thought this was a useful way into this agenda in terms of there is this recognition then that what a health system does, a health system can do more or less around that whole prevention approach. So that analogous to the fire service, that actually a health system which can be very reactive and wait for people to become ill and just simply tackle illness and disease as and when it's arisen, then actually we can broaden that out and think, well, actually a health system with a lot of resources, what can a health system do both in terms of prevention, so conventionally through health systems in terms of brief interventions to help people to stop smoking or advice in and around nutrition and physical activity, etc. But actually much more broader than that, out into the social realm and how people are connected. That's what this report, the kind of questions that it's asking in terms of what can the health system and all of its resources do to help that to happen. And on a similar note then, another well-known health think tank in the UK, the King's Fund, they published this report, Population Health Systems Going Beyond Integrated Care. And you won't be able to see this from the back, but essentially what they had on the x-axis then was what's the focus of intervention, and on the y-axis, the unit of intervention. So down here, we've got care services. So that kind of reactive care service down here, you break your leg, you go into the hospital and they set it for you. There's your care service there. And then you've got your prevention services, your health improvement. So what are we doing around nutrition, about preventing people, children starting to smoke and such like? What's our health improvement? So along that axis, we've got reactive care services, and then we've got preventive health promotion actions there. And then on this y-axis, the unit of intervention, we've got individuals. So we've got care services looking after individuals, so individuals needing, with a healthcare need, seeing their primary care provider, going into hospital, whatever, working on a very reactive basis. And then we've got populations as well, and the example that they've given here, integrated care models. So this idea then that thinking about care services, how do we arrange our care services for population groups? What care services do we provide for frail elderly population, for example? What care service do we provide for people with opiate addiction? So the care service is about thinking about services for individuals and the service delivery for population groups. The health promotion angle, so we've got health improvement for individuals in the same way, and the example in there, making every contact count. So this idea that every contact with a healthcare professional is an opportunity for health promotion. So it's kind of extending that reach to say, well, actually, people come to the healthcare system. They come to it because they've got a health need, but actually every contact is this opportunity to look at the bigger picture and to see the opportunity for preventive interventions. And then up at the system level, so the health improvement and the population is then to think about, so what kind of preventive services can we be providing? And I suppose that the health improvement population, that would be things like vaccination programs, would be a sort of textbook example then, in terms of thinking about sort of preventive action but aimed at the population. So you just want to set that up. What the King's Fund researchers did then was they just extended this model. They said that's your traditional health system then, reactive, preventive, individual, services, and they added on this additional box out here, because what they were alluding to then, and what they put in the box, improving population health requires multiple interventions across systems, is what we already know. It's Public Health 101, that actually our health is a result of the wider determinants of health. So it's to do with our schools and our education, it's to do with our early years, it's to do with the quality of our air and our water, it's to do with the public infrastructure, it's to do with public safety and policing, it's to do with transport policy. It's that health in all policies type approach. So essentially what they were saying was this increasing recognition then that while there's actions that we can take within the health system, that actually there's this much broader set of determinants of health that any health system also needs to think about. So we've got the previous Royal Society of Arts report that I just showed you saying that actually participation is an important determinant, getting people involved, helping people to make connects and take part in things. And we've got the King's Fund then saying that actually that wider social and economic determinants, that much wider world that happens out with the health system, is actually that the health system's got a vested interest in that. And so this is, just a couple more examples, really just developing the same theme. This is actually from the US, where of course, the health system's very, very different. And so this is, this so-called ReThink Health, and the links down there, is really about an attempt to bring together that much wider group of people that was in the King's Fund report there. So essentially what they've got then is that whatever's going on in your health system, in part is arising because of the things that are going on in your wider society. That actually, in order to look at your health system and how well your health system works, you have to look at how everything else in your society is working. And so this caught my eye because it's actually from the US, whereas we know a lot of the healthcare is through health insurance, and so this is an attempt in the US to actually sort of join the dots and draw that whole system approach to thinking about how well does this health system work and what else needs to be connected in. So then finally, let's come to the Scottish National Clinical Strategy. So this is the direction of travel for clinical services. And within this then, specifically thinking about hospital services and thinking about hospital specialists. One is the clinical strategy. What's it saying about the future of the health system in Scotland? And again, I highlighted a number of key points within the text of this document. So first of all, this long-standing policy ambition to increase the proportion of resources going into primary care. So I think like most health systems in the world, in Scotland, the hospital system is an expensive system to run. But this policy ambition then to take the work out of hospitals and put it out into the community, out much closer to where people live. So this diversion of resources to primary and community care from within the hospital budget. A much greater focus on self-management and independence, promoting a focus on prevention, rehabilitation and independence. So this idea that, again, this kind of idea that whereas we built a system that was very heavily dependent on professional expertise, doctor knows best, you take your problem along to the health professional and the health professional fixes you, this increasing recognition that actually the patient, you with your health condition, you're actually a partner in what happens to you. So this idea then that what a health system must do is to help people to live with their long-term conditions. The health system is there to help people to maintain their independence. We'll pick up on that again in the case studies. Provide care that's person-centred. So person-centred is a term which repeatedly rears its head. And it has to be said, means a number of different things to different people. But nonetheless, it's focusing in on the needs of the person and the individual. And then lastly, again, bearing in mind that this is the clinical strategy for healthcare, specialist healthcare system, to understand that the problems of multiple long-term conditions and the resulting loss of independence result in complex needs, many of which are best addressed by social interventions. So there's a recognition in this clinical strategy that actually the health system does not and cannot have a lot of the helpful responses to a lot of the issues and needs that people present to the healthcare system with. So I think across looking at this, looking at what we've looked at so far, we've got this political context where there's a much greater desire to give power back to people and to communities to be able to have a much greater say in how the world works in and around them. And then within the health system, we've got both this recognition that actually health is much bigger than just the health system. We need to think much more broadly than that, and that it's within the health system's interests, the health system having a vested interest in what's going on out in those wider systems. And this recognition that while healthcare has got a part to play in terms of helping people to meet their needs, that there has to be this shift towards working with people rather than doing to people, and that actually part of the solution to some of the issues that people present to healthcare with are actually social rather than health. So, some examples, just to bring that to life then. So thank you for bearing with me so far. That's been quite conceptual. It's a little bit up in the clouds. So let's just, in terms of what does that look like? What does that mean in practical terms? What do you do about that? So let me give you 3 examples. And I promise to give you one from the point of view of the NHS, so the entire National Health Service here in the North East. I promised to give you an example from primary care, and I've also got a couple of linked examples from our multi-agency partnership arrangements. And each of these actually link back to the slides that we've looked at so far. So from an NHS point of view, one of the functions within the health board is to actually have an active team who proactively seek to engage with people who make use of health services. There is an engagement and participation committee, one of the committees of the board, and that is its sole remit. Its remit is to say, how well is the NHS in this part of Scotland doing in terms of reaching out and engaging with and involving patients, their families, their carers, and the public in what we as a health organisation are doing. And in terms of this is just a screenshot from the NHS Grampian website, and a couple of things to point out. So first of all, we've got so some of these this committee that I was talking about, and the ways in which people can become involved. And the patient involvement team, the public involvement team, rather, who actually lead this work. I mean, every month then, they're involved in working with patient groups, working with interest groups, facilitating decision-making fora where there are members of the public there, public-facing communications, etc. That's their entire job. But the other bit to point out then is down here. Here's the link for our community empowerment participation requests. So we've actually got on the front page for NHS Grampian then, there's the link. Any community body that wants to make a participation request, there it is. And I'm going to develop the participation requests before we finish as well. So just to say, as an organisation then, the health system has actually put resources in to this whole issue of trying to engage with people, to hear people's views, to involve people in decision making, to get people who actually use services involved in their design and their development and their delivery. So as an organisation, it's something that we've directly invested in. Let me jump from that, from what the health board's doing, to primary care. And we'll pick up on some of the themes then that we've seen coming through the slides previously. This is Scotland's House of Care, and this is it's a further development of what was originally Wagner's chronic care model. And Wagner's work back in the 1990s then was looking about increasing numbers of people worldwide with non-communicable disease, things like diabetes and heart disease and musculoskeletal disorder like arthritis and such like. And how does a health system respond to that? Health systems developed during the 20th century to really focus in and treat acute episodes of disease, acute episodes of infectious disease and injuries, trauma and such like. What needs to change within a health system when the epidemiology is changing, and we've got this large increase in the number of people with chronic disease. And so Wagner and his colleagues in the States then, their chronic disease model, which was adopted in Scotland as well as other countries, it was really about the management for chronic disease needs to be held in primary care. It's about developing registers of all your patients with particular conditions. It's about having a call-recall system so that you're actually seeing them on at least an annual basis to monitor their results and keep an eye on that. It's about using the evidence base, so applying the best clinical guidance to patient care to make sure that you're across the population, to make sure there's equitable access to the best treatment that's available. So that was Wagner's model. And in light of everything that we've spoken about then, I think it increasingly recognised that the way that model had developed then, let me speak about Scotland, that became a very top-down model. That it was driven very much about bringing patients in, biometrics, so what's your blood glucose, what's your spirometry, et cetera, and prescriptions. And so as we've had a rise in multimorbidity, we've of course got this huge rise in polypharmacy, and it's really because it's driven by a health professional agenda. So Scotland's House of Care was really came from this question of, given all of this policy direction, what would chronic disease care look like in a world where care was shared with the patient, where the patient actually had as much of a voice in what actually happened as the health professional. So in short, what this is about is, rather than, so at the moment the kind of traditional setup then is you've maybe got your high blood pressure and your diabetes and your asthma, and across the course of any given year you'll be brought into a chronic disease clinic for each of those, and you'll maybe have additional appointments to come in and have a bit of monitoring and look at your prescriptions as well. And all of that's done separately and independently. And it's all driven by the guidelines. It's all driven by the algorithm and what your biometrics are saying and whether your dose needs to be titrated and such like. This is an attempt to say, well, actually, let's see the person, not the condition. So rather than bringing you in for your diabetes and then seeing you separately for your asthma and then seeing you separately for your hypertension, it's about saying, actually, we need to see you. You come in and you bring all of your conditions with you. And rather than having lots of separate appointments, actually what we'll do is we'll gather them up, so you've actually got a much longer appointment with your healthcare provider. Be that your GP, be that your advanced nurse practitioner, whoever it is, your practice nurse in the practice. So the system that we've started to roll out and, is being used elsewhere in Scotland, and so we've brought it to the northeast, and we're now rolling this out across practices, learning as we go, is that what happens then is that you get called in, the month of your birth usually, you get called in, and the computer knows, the computer contains all of your diagnoses that you've collected so far, and tells the healthcare professional all the tests that you need to have done, and you have them all done at one time. You go away knowing that you're coming back in 2 weeks to speak to your doctor. And in the meantime, you get all of your results sent out to you, and you get to see what your results are before you come back for your appointment. And the results are set out in an easy to read, accessible format, red, amber, green to draw your eye to perhaps areas of concern, and some prompt questions to think about, well, what does all of this mean? What does it mean for you in your life, and how well you're able to live your life at the minute, so that people come in prepared for their appointment. And this much longer appointment, up to 45 minutes then with a healthcare professional, the agenda that's set then is, what is the patient coming in? What questions do they have? What issues do they want to speak about? And the healthcare professional says, well, actually, I've seen your results as well. Here's the things that I'm worried about. Where do they join? And the agenda is then co-created at the beginning of that appointment. And out of the appointment comes a plan in terms of what are the big issues that need to be looked at, and how are those issues going to be addressed. And what this house represents then is that's what that central circle is. That's that annual meeting to actually look at the person and their life and how well they're living, and all of the conditions that they're coping with. This is about the change in working, the ways of working that actually requires. It's quite different from a traditional healthcare worker's preparation to work in this much more negotiated way. So we need some support in and around that. It's also quite different for patients. Lots of patients come along expecting to be told what to do. So it's quite a different thing to actually be given back the responsibility for your health, to be told, well, actually, this is your health. These are your decisions that you need to make. The responsibility for this actually sits with you. So there's quite a bit of preparation that's required to change the way in which what people expect from their health system. There's a lot of changes to IT and such like that, all the technical detail that we need to take care of. But then this important bit, the foundation of the house, what this house entirely sits on then, is the recognition that actually a lot of what people's needs are, in terms of for people to flourish, for people to live well, for people to be as healthy as they can be, not just physically, but also emotionally and mentally and socially, actually depends on much, much more than what a healthcare system can provide. It's all of the connect, it's all of the what's going on around people in terms of their communities that they live in. We think about a lot of the issues in terms of anxiety and struggling with feelings about what your diagnosis means and what your future holds, isolation, loneliness, difficulties in terms of purpose and meaning. Then actually there's no tablet for that. There's no healthcare treatment for that. But actually, it's about people. It's about society. It's about communities. It's about belonging. It's about being part of things. So part of the important system here is actually having so-called link workers within our practices, and those link workers then, out of this conversation, the link workers are then able to work with that person and say, well, this is what you identified in your plan. These are the kind of things that you would like to do more of, and they know that person's neighbourhood, and they know who the connects are, and are able to take people along, introduce them, involve them in things. Basically, that much more than medicine, get people out into the world and get people involved and participating and taking part. Meeting other people that have got the same condition, meeting other people who've sort of walked that walk already and can so people can learn from one another and such like, is all part of what this model's about. So to me, this is a great example of a health system doing what it does, but doing it in a way of actually involving people, both in their own care, but then also thinking about that wider system in terms of actually there's a bigger picture here, and what systems does the health system have to link people out into that. It has to be said, just as an aside, the beauty of this way of working is that it evaluates extremely positively, both from patients and from health professionals. That for health professionals, one of the common quotes that you get back from health professionals who start to work within this model is what they came into medicine for, is what they came into nursing for, it's what they came into healthcare for. It's actually working with a person rather than doing a series of disjointed tasks with somebody. It's actually working with people. And the common feedback that we get from patients is they suddenly feel heard. They're actually, their concerns, they've actually got time, they're empowered to ask the question. Okay, so lastly then, so we've a little bit about the health board, a little bit there about primary care and community care. So lastly, let me take you into community planning. So that, right back at the beginning when I mentioned the Community Empowerment Act, the one that seeks to transfer power and give people much greater power over their lives and their communities. Community planning was one of the sections of that Community Empowerment Act. And essentially what it does is it puts a statutory duty on every public authority to take part in their local community planning partnership. So this is at the level of local government. So for us in the NHS, here in the North East, we've actually got 3 different local governments. We've got Aberdeen, we've got Aberdeenshire, and we've got Moray. So we've got 3 community planning partnerships. And around that community planning partnership then are all the public authorities. So health, local government services like education, like planning, like roads, fire and rescue, Police Scotland, our colleges and universities, and a whole range of other public authorities as well. And so this is just one example. So this is just an example from Aberdeen City. And I'll give you a couple of examples of what we're doing through this multi-agency approach, which absolutely fits with, if you remember the King's Fund, this idea that there's more to health than just the health system, that actually it's everybody, it's the whole public sector and beyond that actually has an impact on the health of the population. I think this is a great example of, community planning is a great example of that in action, making that real. And so I'll tell you about how we're using community planning as a route into participation. So every community planning partnership's got a board, and the board is the most senior officers, directors, chief execs of the public authorities, along with elected members from local government who sit up and around the board. There's always some kind of management group, some kind of executive group that does the work, if you like, and reports up to the board. And then, as here in Aberdeen, there's a number of different partnership groups who look at specific areas of practice. So over here we've got children's services, for example. We've got a group in Aberdeen looking at sustainability and climate change. We've got a group looking at community justice. We've got a group looking at alcohol and drugs. And some of these are traditional groups that have been long-standing in Scotland to look at, for example, alcohol and drug partnerships are long-standing to look at the whole issue of alcohol and drugs and prevention and treatment and such like. Some of them are based on local priorities within that community planning structure. So I'm going to speak to you about, over here, this community engagement group, and I'm also going to speak to you about these locality partnerships. So just to set the scene for that, essentially, and this is all of Aberdeen, so all of the public sector authorities across all of Aberdeen, these are all the groups then where we come together from all of our collective services to come up with plans to address these particular issues. One of the things that the Community Empowerment Act requires us to do is to actually have a specific plan for our regeneration areas, i.e. our poorest areas, effectively. So we look at our poorest neighbourhoods, and we have to have a specific plan with our poorest neighbourhoods. So I'm going to look at participation in the development and implementation of our so-called locality plans in some of our poorest neighbourhoods in Aberdeen. So we'll take a look at that. And this community engagement group, in terms of that this shouldn't just be a top-down planning structure, that actually with everything that we've spoken about, that actually this needs to represent power to the people. It needs to have people's involvement in terms of the development and implementation and decision-making in and around all of these plans. And so essentially the community engagement group represents some deliberate attempt to have some resource, to have people looking at that whole issue in terms of how do we support the population to take part in all of this. In terms of that Community Empowerment Act, so thinking about participation requests, one of the things that has been done in Aberdeen is all of the partners have got together. Now, if you remember the participation requests, that's a duty on every public authority. So actually every public authority has to make its own arrangements. And if you remember, there's a link on our NHS Grampian website to say, here's where you put your participation request in. What we realised in Aberdeen, though, was that if you were a member of the public, that might get quite confusing. If every public sector organisation had its own leaflets and information and such like. And so we agreed that actually what we would do is we would do it once for the city. So one of the ways in which we did it was we identified some standardised information and some standardised guidance to community groups in terms of how to make a participation request. And then we identified across all of our services who it is that actually has contact with our community groups at the front line, who could actually help people to think about how to get involved and how to do that. So we were thinking about our community learning development colleagues, thinking about our community development workers, thinking about our public health workers who work down at the front line. All of those people are police, community constables, all of the people who actually work right at the front line across all community groups. What we've done collectively then is to say that collectively we've all got the one job to do. And that's to make sure that community groups know what their rights are and how to implement them. And then for locality planning, so this is a map colour-coded against the Scottish Index of Multiple Deprivation. With green being, this was by decile, and so green is the least deprived decile, and red is the most deprived decile. So clearly, if Aberdeen was your patient and you were looking at Aberdeen as your patient, and you were thinking to yourself, where does Aberdeen hurt? You can kind of see your eyes drawn to, well, this is Torry over here. Up here, this is Northfield and Middlefield, Cummings Park, up here in the northeast of the city. And then across here, we've got Woodside, Tillydrone and Seaton coming in at the northeast there. So each of these places has got a locality plan. So the decision was made then that if each of these areas was going to have a development plan, that plan should be developed with and by the people who actually live in those areas. So there's a locality group that's set up to develop the plan in each of these areas. And half of the seats around the table are people who live in that particular neighbourhood. So half the seats are professionals who represent a variety of services who work in that neighbourhood. And then there's recruitment to actually recruit citizens who live in that area to come and join the group. So it has to be said that in terms of developing a plan, that public sector plans have a tendency to be thick, opaque, and quite difficult to read. They're full of jargon, logic models and inputs and processes and outcomes. And for the layperson, well, actually for professionals, some of that can be quite impenetrable. For the layperson, it can be even more difficult. So again, one of the things that the Community Engagement Group did, in terms of the plan that was developed, was basically to say, well, can we write that in plain English? Can we actually just simply take what this plan is and put it into a couple of pages that just says, this is what we think the issue is, this is what we propose to do about it. And so that's what we created here. And the idea being that not only does that make it easier for that locality group to take that out to all their friends and their family and all the other connects that they've got out with the community and say, well, actually, this is what we're trying to do. It also means that when they're sitting around that planning group table, that they can actually much easier ask themselves and challenge one another in terms of, is this really the issue that we've got in our locality? And is this really what we're saying we're actually going to do about it? So actually trying to turn it into accessible graphics and easy to read language, an attempt to make planning much more accessible to the lay public who should be involved in and around that. And what we also did was, in relation to the proposed actions, we also summarised the NICE guidance. So we went away off to NICE and got out, and again, if you've ever downloaded a nice bit of NICE guidance, you'll know how thick that can be. And again, essentially what we did then was we said, okay, this is what they're saying the issue is, this is what they're saying they want to do about it. Let's just present that group with what the NICE guidance says. And again, you know, any piece of selection of NICE guidance and down into sort of 4 or 5 points then, here's what the guidance is suggesting in plain English. So again, that they can think, well, actually, does that have relevance for us? Does that have relevance for what we say that we're trying to do here locally? Okay. We've been on quite a journey there. Thank you for bearing with me. We're almost there. So we thought a bit about this political context, the much more involvement, much more empowerment of people, a much greater say. We've thought about the health system. We've thought about that participation and taking part is part of health, and that actually the health system's got a vested interest in the much wider world that's going on and needs to engage and think about that. And then the examples that I've given in terms of the way that we're thinking about changing our services, that we're transforming our services, and that we're working in this much more multi-agency arena, looking at the breadth of determinants of health, not just within the health system, but much more wider than that. All the possibilities that come from that. So let me just end with a final slide. And this is a graphic that actually came from the Canterbury Health System. So the Canterbury Health System in New Zealand. And it caught the attention of a number of people across the UK, and it caught the attention of some very senior people in the Northeast as well. And I think what's nice about it is it just captures in a picture everything really that we've been speaking about. So in this case, here's the patient in the middle, this older lady there with her house. And then the system itself wraps around her. So the first thing to notice is that in terms of this whole system, first of all, the hospitals are distant. The hospitals are way out on the periphery. So they're there if she needs them, but they're not central to this whole system. Now, we've got a whole range of health activities going on in terms of primary care and urgent care and community nursing, etc. But it's also capturing that the health system also legitimately has an interest in people's activity levels and the kind of green space that people have got to take exercise in. So the health system's got a vested interest, for example, in town planning and what local government's doing in terms of green space. Nutrition and the availability of healthy food and food growing. Not traditional things that you would think a health system might necessarily be thinking about, but actually things that the health system has got a vested interest in. What is the food supply like for its local population? And what are the opportunities for connection for that patient in their wider community? So it's saying that a modern 21st healthcare system isn't just about the technology of delivering healthcare. It's actually thinking about the person and the whole system that wraps around them. And I hope then that the examples that I've given you go some way to suggesting that we are thinking about this and what this means for our population in the northeast of Scotland. I think we're there. I don't know whether there's time for questions, but thank you very much for your patience and your attention. Thank you.